All right, good afternoon and welcome to this live webinar put together by Banner Health for the Northern Colorado community. Today we'll be talking about atrial fibrillation, or Afib, and we'll be talking more about the condition as well as some of the latest treatment options. So excited. Joining us live, we have Dr. Mark Tuttle. He is an interventional cardiologist, and also joining us, we have Dr. David Bicknell. He is a cardiologist specializing in electrophysiology. So excited to have both those doctors with us today. For viewers at home, if this is your first time joining us, one of these live webinars, some housekeeping items we have for you to go over, give you an idea of how the show is going to go today. Both doctors will share a little more about their background and the work they do every day. Then we'll get into some discussion on critical information about Afib, and we do have some pre-submitted audience questions we'll be answering. And then throughout the show, if you feel the need to ask a question, please feel free to use that chat feature on your screen, and we'll try to get to as many of those live questions as possible. Reminder, this is a live streaming event, so at any time if the stream goes down or you lose your connection, we just recommend logging off and logging back on, as that tends to fix it. Also, because this is a live streaming event, you can share this link out to anybody you feel needs to hear this information or wants to join the conversation. All right, Dr. Tuttle, let's start with you. Tell us a little bit more about your role at Banner Health and your background.
So I'm, as mentioned, what's called an interventional cardiologist. So in addition to seeing patients in the office, I also perform procedures that can help patients feel better sooner. And that includes in patients with atrial fibrillation, and particularly a left atrial appendage closure procedure so that patients can come off of blood thinners. I'm originally from Michigan, did all of my medical training in the Boston area. I'm really happy to be joining the Banner team and living in the mountains out here in the Rocky Mountains, and really excited to be seeing patients out here and hopefully making people feel better and live longer.
Thank you so much. All right, Dr. Bicknell, a little bit about your role at Banner and your background.
My name is David Bicknell, and I'm a cardiac electrophysiologist, or EP for short. And I've been at Banner about 2 years now. And I'm originally from Chicagoland area. I did med school in Des Moines, Iowa. Subsequently did several training programs in Chicago. And I did my electrophysiology training in Kansas City for 2 years. Then I was in practice for about 8 to 9 years in Chicago, as well as Columbus, Ohio, before moving out here in December of 2020 with my family and enjoying Northern Colorado. Regarding electrophysiology, it's a little different than what Mark does. We do treat atrial fibrillation in different manners, including ablation, pacemakers, as well as left atrial occlusion devices, which we'll be talking about mostly today.
All right, so before we get into the pre-submitted audience questions, and I do want to remind the audience, as we have new viewers showing up throughout this webinar, you do have the opportunity to ask live questions. We'll try to get to those questions as soon as we can. But first, let's sort of define Afib, and I guess either one of you can kind of take it, but what is Afib exactly?
Yeah, I'll start with Afib. So atrial fibrillation is one of the most common arrhythmia disorders in all ages. It typically exists usually in people in their 40s or 50s, 60s, 70s, and all the way into people in their 80s. It's the most common arrhythmia in people in their 80s, and about 10% of people in their 80s have Afib, but a lot of people in their 50s, 60s, and 70s have it. It's an irregular heartbeat where the top chamber of the heart beats somewhere between 400 and 600 beats a minute. It doesn't mean the bottom chamber then responds in an irregular pattern, which can be controlled at rates between 60 and 100, or sometimes they go quite fast, and people are very symptomatic with shortness of breath, difficulty breathing, exercise intolerance. People can be in and out of atrial fibrillation. They can go in it for several minutes to hours, or they can be in it persistently over weeks at a time. So that's atrial fibrillation, and we treat it with 3 different ways. First, we talk about blood thinners and anticoagulation to prevent stroke. As the heart is irregular, clots can form in something called the left atrial appendage, and We talk about anticoagulation as well as different ways of occluding this appendage, which we'll talk about today. The other way we treat is controlling the heart rates with medications. Typically, these are beta blockers such as metoprolol or diltiazem such as calcium channel blockers. They have some side effects, so people often want treatment getting rid of the Afib, and that would be something called an ablation, which we also do as well, which is quite commonly done, especially in 2022 and 2023. And last is we can use medications called antiarrhythmics, which have fallen out of favor over the last couple of years due to side effects. But that's, go ahead, Mark, if you want to continue on that.
I think that's a really good assessment, Dr. Bicknell, and I'll just add that it's really nice at Banner that we have kind of a multidisciplinary team. So we're both cardiologists, but I'm an interventional cardiologist, which means I'm more like a plumber, and Dave is an electrophysiologist, and he's more like an electrician. And we can attack these problems from two different angles and two different perspectives, and really kind of come up with the best solution for a given patient, whether that is meds, whether that's a procedure that Dr. Bicknell does or I do. And I'll just add that AFib is tremendously common, just as he mentioned. And in patients who are, or people who are born today have a 1 in 4 lifetime chance of getting this condition, 25% lifetime risk. So it's a really important thing to know about, recognize, and be aware of the treatment options.
All right, so you're just talking about some of those symptoms and maybe who's at risk. So some of the pre-submitted audience questions we have, one of them is this hereditary?
Dr. Bicknell may be able to speak more about some of the genetic inheritance patterns, but it's often an acquired condition, at least most commonly. There are, I think, uncommon genetic predispositions to this, but the run-of-the-mill AFib is really kind of from some of the other what we would call risk factors. So high blood pressure, diabetes, being overweight, some of those things can lead to atrial fibrillation. And those other things also seem to run in families as well. So in a sense, even the risk factors can be inherited. It's pretty uncommon to have a genetic mutation that causes atrial fibrillation. But Dr. Bicknell, please tell me.
Yeah, there are some genes that can cause atrial fibrillation. They're not common. We believe it's less than 2% of atrial fibrillation, and they're usually people who have Afib without other risk factors, usually in their 30s or 20s or 40s. And it's really, there's a couple genes, and the most common one is more of a Norwegian Caucasian type of gene. But having said that, genetics is complicated. And as Mark said, usually if families have coronary disease for other reasons, high blood pressure, obesity, lack of exercise, then sometimes their children do too. So that's oftentimes why it almost seems in the family, because somebody will say, well, my dad had it or my mom has it. And it's more, as what Mark said, it's usually within families because of other risk factors.
Okay, so another question that has come in, what will happen if I do not treat AFib?
So I'll take this one, Dave. And what I would say is that the biggest thing people are worried about with AFib is the risk of stroke. And I think that's the biggest drawback to not seeking treatment is, strokes can be devastating. You can lose your ability to speak, lose your ability to, live independently and have your sense of quality of life. I think that would be, if I would identify, that's the biggest thing that people are worried about, appropriately so, and why they seek treatment. Patients certainly can also have other symptoms, but only 50% of patients with AFib manifest with significant symptoms. So it can be a silent thing, but that doesn't mean that it doesn't need treatment. So even if you do not feel the symptoms of AFib, you should still seek out treatment because of the silent, risk of stroke.
Yeah, and with AFib, a lot of times people have decreased or difficult exercising or decreased walking up hills or even, and out west, it's definitely people notice it when they're on hikes or in altitude. And we've treated people who just get it when they're in altitude and they just don't want to have atrial fibrillation. Strokes is the biggest prevention that we do. for preventing stroke. And not everybody has the same risk. So a 50-year-old man without any other risk factors might not have the same risk as maybe a 75-year-old with diabetes and high blood pressure. So risk of stroke varies, but the symptoms or the feeling of the heart racing and difficult exercising or doing daily activities can exist at all ages. So we definitely try and treat it. And as Mark said, some people don't even know they have it until they show up to a doctor's office for a regular checkup and they're found to be in it. So.
Thank you both for those answers. A reminder to the audience joining us, this is a live stream event. We've got both doctors joining us via video conference, and if you are watching this live, you do have the opportunity to jump in, ask questions. We'll try to get those questions to our doctors, but again, they are joining us via video conferencing today, so really excited to have them with us and have the ability here to answer some of these questions live in the moment. All right, another question that we had come in, and you mentioned blood thinners. What are the pros and cons of blood thinners?
I'll let Mark take this one. Go ahead. Yep.
Sure. So the issue with blood thinners are that it's a balance, and the way that people get strokes in atrial fibrillation is by forming blood clots inside a certain chamber in the heart, and those blood clots break off and they can go to the brain and cause a stroke. Now, blood thinners, they effectively treat these clots. They prevent clots from forming, but it's really kind of treating a patient with a systemic therapy, something that goes to your whole body, really for a local problem that's just occurring in the heart. And for patients who have no problems taking blood thinners, and the problems being bleeding, falling, or being in a occupation where injuring yourself could be really, really serious, like commercial drivers, farmers, pilots, things like that as an example, blood thinners can be problematic. So on one hand, they are really effective at treating patients and preventing stroke. But unfortunately, on the other side of the token with regard to blood thinners, they can cause bleeding. They can cause gastrointestinal bleeding. They can cause, if you fall a lot and hit your head, that can be dangerous. So the nice thing is that we have other therapies that are available now called left atrial appendage closure devices that are FDA approved, and we Dr. Bicknell and myself both perform this procedure to put a device inside the heart to protect you from stroke and enable you to come off of blood thinners and still be protected. So it's not for everyone, particularly if you're having no problems whatsoever on a blood thinner. Why have a procedure then? But if there's any difficulty taking blood thinners, or if you're in a high-risk occupation or have other reasons, then it's something that we take care of, and we take care of effectively. It's a straightforward procedure, and nothing is risk-free with the heart, but it is exceptionally safe. Come in the morning, go home in the afternoon, and the problem is taken care of.
So it looks like there's a question here regarding, is it LAA? Is that the acronym for the procedure?
LAA is called left atrial appendage, and the acronym is left atrial appendage closure, technically, or left atrial appendage occlusion. The left atrial appendage is the structure within the heart where the blood clots form in Afib. That's the structure we plug up, basically, with this procedure in order to get patients to be able to come off of blood thinners and still be protected against stroke.
Okay, can you walk us through then the steps to qualify for the LAA closure?
Yeah, sure. Dr. Bicknell, do you want to take this one?
No, you go ahead. Go ahead.
So, it is what's called shared decision making. So, Dr. Bicknell and I see patients in the office who are interested in this procedure, and we basically have a conversation, and we go through the pros and the cons. Everything is about balancing risk and benefit in medicine, and particularly in procedural fields. But strictly by the designation of the FDA, the people who are candidates for this procedure are those who are suitable for short-term blood thinners, but felt to be poor candidates for long-term blood thinners. So what does that mean? That means, well, you can be on blood thinner for a short period of time. You don't have a major active bleeding issue. If you're actively bleeding, we can't do this procedure on there. But if you have a predisposition to bleeding, or you fall, or you're a high-risk occupation, as I mentioned, then you would be felt to be a good candidate. And those types of patients we evaluate, we discuss, we talk about the procedure, the risks as well. Even though it's exceptionally safe to do the procedure, it's still a procedure on the heart, which we don't take lightly. And we make sure that patients and their families fully understand the risks and the benefits. The benefits being able to come off of blood thinners, the risks of the procedure being having a bleeding problem where we go into the blood vessel, or having internal bleeding. Now those are exceptionally low risk, but they're not zero risk. And it's important in our visits that we talk to patients and families and make sure everybody's on the same page before we make a decision.
Dr. Bicknell, anything you want to add to that?
Yeah, as Mark said, a lot of times people are interested in these closure devices or occlusion devices, and they don't treat the Afib specifically, but they do. So you still have Afib for those people. So if you're, and there's also one thing that's important is you have to have a certain score. We use something called a CHADS VAS score. You have to have a score of 3 currently in the current FDA approval and insurance approvals for this. So they're not, so if you're, and the scores vary based on age. If you're, you get a point for being a woman, a point for being 65, another point for being 75. If you've had a previous stroke, and that stroke can be any type of stroke essentially, that gets you 2 points. So this isn't a scoring system you want to get points for, but if you get a score, if you have a score of 1 or 2 or 0, then you're not a candidate for the occlusion device. However, those are typically younger people who don't have as many risk factors, and they're the ones we typically do ablations on to treat the Afib. And that's another discussion of what happens long term, but usually those people we try and eliminate or decrease the Afib burden on people. But the closure devices are for people who have higher risk. Previous strokes is a big issue because people have had a stroke, and that usually signals them they're a little more aware and they want something more aggressively done, as Mark said.
All right, a reminder to our audience just jumping in, this is a live stream event. If you do have questions you'd like to ask our doctors who are joining us through video conference today, please feel free to use that chat feature. We'll try to get those questions across. We do have some more pre-submitted questions to get to, and it looks like a lot of the pre-submitted questions, doctors, are on this closure. So is the LAA closure a permanent solution? I'm not sure if you guys went into that or not, but I do want to follow up. Is it a permanent solution?
Yeah, I'll start to answer this one, and Dave, please tack on, because we both perform this procedure, and I'm sure we both have takes on it, although I think we kind of have a unified approach to it, which is nice. What I will say is that ideally, yes, it's a permanent solution to the stroke problem of Afib. If we get, the idea is the blood clots form in this certain chamber of the heart, and the blood thinners prevent that, but if you want to come off blood thinners, we can plug up that hole so that the blood clots can't get out and go to the brain. And if we have procedural success, meaning that we're able to close the appendage with one of these devices, one of them is called Watchman, which many people have heard of, the other one is called Amulet. If we're successful in closing that, then yes, it's a permanent solution to the stroke issue. And the if there is a 98.5% chance that we're successful at closing the appendage. So very, very likely to be a permanent solution. Small percentage of people, either that plug doesn't fully cover the appendage or there's a leak around the side of it, things of this nature. But in the vast, vast majority of people, it is a permanent solution to the stroke issue with Afib. As Dr. Bicknell may want to speak about, it doesn't cure the Afib, it just prevents the stroke aspect of it.
Yeah, the stroke aspect has been key, and these occlusion devices have been thought of for over 20 years. In fact, the original trials were done almost 17 years ago. The approval process took a long time, but eventually over the last 5 years, it has significantly been approved and increased by insurance payers to pay for this. And a lot of times just people on blood thinners, specifically, there are several types of blood thinners. There are 4 medications that people can take by mouth that don't have to be monitored. And then there's, of course, Coumadin or warfarin, which is actually cheaper. However, it has a little more side effects to be used for monitoring and things like that. So a lot of people just want to be off the blood thinners for, as Mark said, different reasons, falling easily, occupation. And in Colorado, a lot of people, we see some skiers or active hikers that really don't want to be in blood thinners in the middle of places. Skiing, if you do ski, definitely it's one of those that we highly recommend.
All right, let's talk a little bit about
the blood thinners because of the nature of
the day of the procedure. Some questions around what can someone expect when they're going through one of these procedures at the hospital. I know, Dr. Tuttle, you touched on it earlier. You know, you might be in and out that same day, but is that the case for all these procedures?
Yeah, that's the goal anyway. Now, there's going to be, from a procedural standpoint, it is completely safe to have a same day discharge, meaning you come in and then go home the same day. Sometimes for social reasons, or here in rural Colorado, sometimes we get patients from very far away and they want to stay overnight because they feel safer, and that's reasonable as well. But from a safety standpoint, it is absolutely safe and has been proven to be safe to be able to come in the morning and go home later that day. And if you don't mind, I'll expound a little bit because it sounds like viewers are very interested in this, on what the logistics of the day of the procedure are like.
Yes.
So a typical patient that comes in will come in the morning. They'll go into a procedure room. They'll be under general anesthesia, meaning they'll be completely asleep for the procedure, won't remember a thing. While they're asleep, a camera is put down into the throat, in the esophagus, because the esophagus goes actually right behind the heart. And through that camera, we get really good pictures of the heart, and specifically the left atrial appendage. And once we figure out what size the appendage is, which is the structure we're trying to plug up, then we know what size plug to use. And either myself or Dr. Bicknell would then use some equipment and make a hole about the size of your pinky in the vein in your leg, in your groin area, the femoral vein. And from there, we go up inside the heart, plug the hole, make sure the plug is nice and secure. We even tug on it to make sure it's not going to come out. And once we're satisfied with that, we release the plug, take the camera out, wake you up, make sure you're feeling good, and then able to get out of the hospital and go home. The procedure, honestly, a lot of the time is spent during the preparation and getting you off to sleep. The amount of time that Dr. Bicknell or I spend with equipment inside your heart is less than an hour. It's probably 45 minutes. So it's pretty quick. It is very safe, though nothing, when you're doing a heart procedure, even if it's minimally invasive, is 100% safe, which is why we have a conversation about it ahead of time. But in the vast majority of patients, they do excellent, and they're able to go home and stop their blood thinners.
So that's go ahead, Dr. Bicknell.
Yeah, I was going to say, this is definitely a team approach. So there's actually 3 physicians involved at the same time. We have the anesthesiologist, which may be a nurse, anesthetist, but there's a provider there doing the anesthesia the whole time. We also, in our practice, have a cardiologist, specifically an echocardiographer, taking the pictures with the with the transesophageal echo, and then the physician, as well as about 4 different staff that assist. So it is a team approach, and there's quite a few people in the room that make this quite safe, and the very, very experienced group of individuals.
Well, let's now talk about, as we close up the session here, following up after these procedures. Let's talk about what that process looks like. Is it necessary? What's my journey like after the procedure?
Yeah, Mark, I'll let you take this one. This is changing here and there. So this has definitely changed over the last year, I would say. Go ahead, Mark.
Absolutely. There's even been a change as recently as a couple of weeks ago. It used to be the case that you needed to stay on your blood thinner for at least 6 weeks after the procedure. That has since actually been revised by the FDA, such that for any of the available plugs that we have from the 2 different manufacturers I mentioned, both of those have the option to stop the blood thinner right away. So follow-up, what I'll say is first is with regard to kind of activity restrictions after the procedure like this. You can go ahead and resume normal activity. There are no cardiac limitations, but we do want to make sure patients are mindful of that place we went into the vein in the leg. And we don't want patients to lift heavy things and kind of just take it easy for a couple of days until that area heals up fully. But follow-up is necessary. Particularly, we ask all patients come back in 6 weeks, and this is mandated by the FDA, that patients come back to take another picture of their heart. And that would be a transesophageal echo, like I mentioned. Again, a same-day situation. And the reason for that is we want to make sure that plug still looks really good. And after 6 weeks, your body has started to grow over the plug, and you almost like develop a layer of skin on the inside of your heart. It's called endothelium. But the device, which is metal, eventually your body grows over it, and it's almost as if it was never there. It doesn't get reabsorbed. It's metal, it's always there. But the follow-up is we want patients to come back in about 6 weeks for a transesophageal echo to make sure that the device still looks really good, is still plugging the appendage fully, and there are no leaks that have developed or blood clots have developed.
Quick follow-up question, always a common question here. Is this something insurance does cover?
Yeah, so this is definitely, I would say over the years has been harder. But the last several years, the insurance companies definitely approve this far more than not. Several years ago, and people may have had experience with this, where the insurance companies wouldn't cover it. But the last couple of years, it has definitely been approved far more. Yeah, it does take some pre-approval. So we do see people, we get it pre-approved, and almost all insurance companies now, commercial insurances as well as Medicare, and insurance companies that back up Medicare and Medicaid approve this regularly without too much difficulty. What do you think, Mark?
Yeah, we work closely with our nurse coordinator who handles all of the approval process. She has not once come to me and said that, oh, we can't get this patient's insurance approved for this procedure. And I actually think that that speaks to the effectiveness of the procedure because, insurance companies, they're number crunchers, and they've figured out that this procedure is effective and it's actually cost effective for them because if patients can come off of blood thinners, they don't have to pay for the blood thinners, and patients don't have to pay for blood thinners that can be very expensive out of pocket. But they've also done analyses, if patients are falling or have other risks, it's better to have this plug in place and have patients come off of blood thinners. So I think that, implicit in how easy it is to get it approved now is the fact that it has been proven very effective, and that's come to the insurance company's attention. They've crunched their numbers and figured out, oh, this is something that we should pay for and support because in the long run, it's cost saving.
Well, doctors, you've both been fantastic. Such great information. I do want to kind of close out giving you the opportunity for some final thoughts. So Dr. Bicknell, we'll start with you. Just, everything we've talked about here today and kind of just sum up, the advancements and what people with AFib or family members can expect and just, kind of close us out here as we've had this very informative webinar.
Yeah, I would say patients with atrial fibrillation, once you're diagnosed or self-diagnosed, some people diagnose themselves on Apple Watches, smart watches, things like that. Once you're diagnosed, sometimes seeking treatment with a specialist, such as Mark or I, is important because a lot of times people see their primary doctor and they're sometimes they're not fully treated with the options. So sometimes just being able to see us to discuss different options for AFib is important. And that's one of the biggest things we see. So asking your doctor, can I see a specialist or should I see a specialist regarding AFib is actually quite important. That's one of the best steps they can make. And we try our best to get people in. Seeing a cardiologist in general can then refer sometimes to subspecialty like Mark or I. And
Dr. Tuttle, before we close, I'll just remind everybody, yes, you see the phone number there on your screen to make an appointment to see a specialist. So Dr. Tuttle, just some final thoughts here as we close out today's show.
It's really a pleasure to be invited to be on and to reach out to patients. And, I just couldn't be happier working at a place like Banner in the team approach that we really have. Myself as the plumber, as I mentioned, and Dr. Bicknell as the electrician, we kind of attack things from multiple different angles. And, you have a care team, and we come up with personalized medicine, not a one-size-fits-all approach. And I'm really proud to be part of this team, and I think that we do a really good job. And I think we do a really good job, engaging with patients and coming up with whatever the right solution is for you.
Well, Dr. Tuttle, Dr. Bicknell, thank you so much for sharing all of this information. And I want to thank you for attending. If you found this information helpful, as a reminder, as soon as this event ends, it will be available for you to stream and share. Just use that link that you're watching it on right now. And a reminder, there is the phone number there if you do need to make an appointment and you want to see a specialist. So thank you so much for attending. Thank you for watching, and we'll see you next time.